So there are strategies that we can use to improve fistula healing. And so this is probably one of the most important parts of the talk here. So anyone in the audience who have had problems healing their perianal fistulas, there can be reasons why it's difficult to heal. And some of these reasons we can potentially modify to improve success. So if you're only going to remember one slide, this is probably the most important one. So if we think about the reasons why fistulas don't heal, well, the first and one of the most obvious ones is that the fistulas can be very complex. And so we're currently doing a multi-center study in Canada, and we also have some centers in the US, and we're trying to look at patient factors as well as radiographic factors from the MRI scans to see if we can predict which patients are more likely to heal versus which ones will not. Now, unfortunately, with complexity, you can't really do much about complexity. But we've also come to realize that if you have inadequate or very low levels of medication in your system, you're less likely to heal your fistulas. So this is something that we can modify. We can push the doses of our medications. Another important cause of a non-healing fistula is because there is a persistent infection or a persistent abscess that hasn't completely drained. So again, this is an example of where the gastroenterologist and the surgeons have to work together. And so there will be times where I will ask the surgeons to take another look and to drain any undrained abscess. The next idea is the concept of dysregulated inflammation. So what does this mean? Well, simply put, you can think that there are multiple different pathways that lead to inflammation. And so because we use these very targeted medications to block inflammation, we don't always block each and every one of the inflammation pathways. So it might mean in the future that we can combine different medications to improve or to achieve better healing. This next concept is one of the most commonly forgotten reasons for poor fistula healing, and I think it's probably the most important. And so this is the concept of a high pressure zone. So with Crohn's disease, because there is chronic inflammation, it can often lead to scarring. And when scarring occurs in the bowel becomes more and more narrow. So the same thing can happen if there's inflammation in the anal canal. And so you can imagine if that anal canal became narrower, tighter, it's going to be more difficult for the stool to exit the proper way. And so if there's a high pressure zone because of this narrowing, this will cause the stool, it will force the stool into the fistula tract rather than out the normal exit. And so this is something that we can fix by repeated dilation of the anal canal. And so I often tell my residents when they're learning about perianal Crohn's disease, I tell them that always make sure to do a rectal exam to make sure there isn't narrowing in the anal canal. And if there is, it's going to be very, very hard to heal the perianal fistulas unless you deal with that. So the last concept is something known as epithelialization. And so I want everyone to think of if you've had your ear pierced. So when you have your ear pierced, the hole that's created, it takes a while for that tract to mature. When that hole matures, you start to grow a little surface layer of skin over that hole. And once that happens, it's very difficult for that hole now to completely close. Well, the exact same thing can happen with these fistula tracts. And so this is, again, another situation where we really rely upon surgeons for help. And so the surgeons can actually go in and they can do something what's called curettage, and that's kind of scraping the layer, that surface layer of skin from the fistula tract. And once that's done, it's felt that it's more likely now that the fistula tracts can close. So there are 6 possible reasons that I've listed here why fistula tracts don't heal, some of which we can potentially modify to improve healing. So let's look at some of the studies that support these reasons. Well, first of all, this is an old study that was published back in 2003. It was a very small study, but what they wanted to do is that they asked the question, if we combine Remicade with a local surgical procedure, so if we do the 2 together compared to Remicade alone, can we help heal more fistulas? And so they looked to see if the fistulas responded. And when you combine surgery with Remicade, you can see that there are higher rates of healing. And when you combine the 2, it was less likely that the fistulas would recur. So because of this study and others, it's thought that, it might be important to have that exam under anesthesia with the surgeons prior to beginning our anti-TNF therapy. So I must point out that these studies which led to this conclusion are very small, and they're not formal randomized controlled trials. So we have to take this information with a grain of salt, but it's a potential way to help. So the next idea is combining our treatments, our anti-TNF therapy, with antibiotics. And so this was an actual formal randomized controlled trial. And in this trial, they were using Humira as a treatment, Humira as an anti-TNF therapy. And they randomized patients to receive Humira with an antibiotic or Humira alone without an antibiotic. And patients were given a very liberal course of antibiotics. They were treated with antibiotics for a full 3 months nonstop. And after that 3-month period, they looked to see how many patients responded, their fistulas that responded. And you can see here that with the combination of antibiotics and Humira, many more patients responded to treatment compared to using Humira alone. And then if we look over at complete healing of the fistula tracts, again, you can see that the combination of antibiotics and Humira works better than Humira alone. So this study tells us if we use antibiotics for a finite time, that can improve fistula outcomes, at least in the short term. What we don't know is if that also translates to long-term healing. So even in this study, they looked not only at 12 weeks, but also at 24 weeks. And you can see the difference between the 2 groups starts to lessen. And so again, this brings into question if this strategy, early antibiotic use, will have a long-term impact. So the next study that I'm going to present, and the final one for this part of the talk, this is a study that was presented at one of our major international conferences back in 2016. And so the authors wanted to know if the concentrations of Remicade impacted healing. So they measured the levels of Remicade inside our patients' bodies, and they looked at healing. And so here in the orange, these are the rates of fistula healing. And you can see that as the concentration of Remicade increases, so does the percentage of patients that achieved healing. And so it appears that the sweet spot is a Remicade level between 10 and 20. Anything over this value, and you don't really get much more of an added benefit to Remicade. So this really changed our thought process with our anti-TNF therapy. And so most of us now are a lot more aggressive in pushing the doses of Remicade and Humira. Now, one of the things that my patients often ask me, well, if I'm increasing the doses of Remicade or Humira, is that not more risky? Am I at a higher risk of side effects? And the answer is, so far, we have not seen any added risk of side effects from increasing the dose of Remicade or Humira. So it's very encouraging. You may get a better clinical benefit, but without any additional risk.